I am the Deputy Director and Chief of Radiation Oncology at the Miami Cancer Institute, and I'm Chair of Radiation Oncology at Florida International University. I used to be a faculty member at the University of Maryland, and that's when I inherited this mantle of giving this specific talk, which is the radiobiological aspects of alternative delivery strategies. And the definition of alternative strategies keeps on changing all the time. It clearly includes brachytherapy, which I'm not going to touch upon. It should include radioisotopes. It should include theranostics, and I'm not going to touch upon that either. I'm really going to focus on radiosurgery and proton therapy, which is what I've historically focused on. But this year I introduced a little bit at the tail end on neutron therapy because I think there are some good reasons to be thinking about neutron therapy. There are usually one or two questions on the board about that, but more importantly, because there might be resurgence of some forms of neutron therapy. So that's the context of my talk. My confluence of interests, I prefer to use the phrase confluence rather than conflicts, because conflicts implies a negative connotation, or the last 2 years are illustrated here. And I have divided my talk into 4 parts. So these are the 4 objectives. I'm going to review the radiobiological assumptions and the clinical implications underlying extreme hypofractionation. And by extreme hypofractionation, we are really referring to radiosurgery and to some extent aggressive fractionated stereotactic radiotherapy. I will also review the radiobiological assumptions underlying proton therapy, specifically as it pertains to the relative biological efficacy, the RBE, of proton therapy, and discuss why that's problematic, what the variations therein imply, and what it means in terms of practice, and how this is an increasingly common and growing problem with the increasing number of proton therapy facilities that are now across the nation. I will review some alternative biological phenomena that are associated with proton therapy that go beyond the conventional R's of radiobiology, but are important in terms of clinical outcome and why the practicing radiation oncologist needs to pay attention to these phenomena. And then I'll end by briefly reviewing neutron therapy. I've thrown in a couple of questions at the tail end that we can try and go through as an exercise. So let's begin with the radiobiology of dose fractionation. You've seen this in several talks. You'll see this again and again, and it's crucial that you understand this. And when it comes to altered fractionation, when it comes to radiosurgery or large doses per fraction, this is critical in terms of understanding. As always, we begin with the cell survival graph. So this age-old methodology of trying to understand what happens to cells and tissues after radiation and after varying radiation is critical. What's crucial is to understand the blue curve on this graph. The blue curve is a single dose of radiation, and as the dose of radiation goes up, the higher the dose of radiation, the less the surviving fraction. On the x-axis, you see the dose. On the y-axis, you see the surviving fraction. You start off with a surviving fraction of 1. In other words, all the cells are intact, everything is alive. You give higher and higher doses, fewer and fewer cells survive. The surviving fraction diminishes with single doses of radiation. Whenever we fraction it, and you see examples here of 3 and 5 fraction radiation, the slope of this curve gets shallower and shallower. In other words, 3 and 5 fraction radiation, or any schedule of radiation, is a relatively inefficient way of killing cells compared to single dose radiation. Single dose radiation will always be, according to this model, the most effective and efficient way of killing cells. And the more we fraction it, the less efficient we get, and the higher the dose that we need to achieve the same endpoint. In other words, we have wasted radiation, and there are good reasons why we waste radiation, as you will see in a bit. There is, of course, a limit to this. This is the limiting slope, which is at the very low dose rate, and that's like continuous low dose radiation, and that's the slope you get that's in orange at the top of this cell survival plot. Now let's start by defining what we mean by large single doses or a few large single doses. In other words, let's try and put some definitional structure around radiosurgery and stereotactic body radiotherapy. So conventionally fractionated radiotherapy is very easily described. It's 1.8 to 2 gray per fraction, typically delivered as 4 to 5 fractions per week, typically a course of 4+ weeks. And this is something we do in routine practice in many of our patients. Technically, hypofractionation is anything that's a dose of greater than 2 gray per fraction. So if you do 2.1 gray per fraction, that is technically hypofractionation. But in reality, that's not what most of us think about when we think about hypofractionation. Because what we are really thinking about is not this moderate hypofractionation of 2.5 to 3 gray per fraction, which is commonly used in clinical practice, and there's extensive experience for it, and we don't really even think about that as hypofractionation. What we are really thinking about usually is extreme hypofractionation, that as is practiced, for example, with stereotactic radiosurgery, where doses equal to or greater than 15 gray per fraction, typically in 1 to 3 fractions, are used. So there are two things here you need to pay attention to. Number one, the dose per fraction is very high. As you can see, it's in the range of 15 gray or thereabouts. Number two, the time has now been compressed. We go from 4, 6, 8, 9 weeks of radiotherapy down to 1 to 3 fractions. So there's compression of time and there's escalation of dose per fraction when we do extreme hypofractionation. And intermediate hypofractionation, as you can well assume, is something in between. So we do compress time because we typically use 5 or so fractions. It's not as compressed as 1 to 3 fractions. And we do increase the dose per fraction, but it's not as high as it is with radiosurgery. And so the dose per fraction is typically in the 3 to 8 gray per range. This is frequently and typically used in stereotactic body radiotherapy or SBRT kind of approaches, intermediate stereotactic body dose per fraction hypofractionated regimens. Now let's look at a few examples and their implications. An example of moderate hypofractionation would be, for example, a 75 gray prescription delivered in 5 weeks at 2.5 gray per fraction. This is typically delivered, say, for example, with a curative intent in some tumors. The converse of this would be extreme hypofractionation, where we could deliver the dose in 13.5 gray per fraction and do this all in 2 weeks. So this is now very extreme. Both of these imply biological change of fraction size effect and inherently, as I pointed out, acceleration of delivery. In this particular example, the implication is that we're going from 5 weeks all the way down to 2 weeks. And this is very relevant, especially in A, rapidly proliferating tissues, and B, rapidly growing tumors. So remember that when we deal with hyperfractionation, think of the effect both on tumor and on normal tissue as a function of both dose per fraction and acceleration of radiation dose delivery, compression of time. In this context, which R's of radiobiology are the most relevant? We know if we look at the critical R's for accelerated delivery, there would be recovery and repopulation. Although radiation sensitivity, redistribution, and reoxygenation are important, they are significantly less important than recovery and repopulation are when it comes to delivery of radiation in a compressed time period and in large dose per fraction. So recovery is central to fractionation because it is a crucial effect of dose per fraction. The greater the dose per fraction, the less the recovery. And repopulation, accelerated repopulation, which is displayed by tumors, is significantly modulated downwards if we accelerate the radiotherapy delivery and shorten the radiation course. And therefore, this can have an impact on cure and outcomes because we don't have to deal with the extra dose that is now necessary if we are chasing our tail by giving small doses per fraction and the tumor is accelerating, repopulating during this period of time. Let's start by looking first at the recovery effect. The recovery effect can be equated loosely with repair capacity. All tissues repair between radiation fractions. All tissues do this. Some do this better, some do this worse, but all tissues repair to some extent. Simplistically, higher fractional doses result in less repair. So if tissue A is capable of a certain amount of repair at, say, for example, 2 gray per fraction, and we now deliver 10 gray per fraction, that tissue A will repair less efficiently and will yield less repair. And this is true across the board for all tissues and tumors. The implication here is that with fewer fractions, less total dose is necessary to achieve the same effect. And that's why if you treat a benign meningioma at 1.8 gray per fraction, you need to go to 54 gray in 30 fractions. When you treat that same small benign meningioma with single fraction stereotactic radiosurgery, a dose of 12 or 13 gray is sufficient. So less total dose is necessary for the same effect with fewer fractions. This effect, of course, varies by tissue. And this variation by tissue is a function of the repair capacity of that particular tissue, which is reflected in the linear quadratic model that Dr. Miller just described to you so elegantly in the last talk. The key message from there that is relevant to this particular talk is that tissues, and for that matter tumors, with lower alpha beta values, and remember tumors typically have higher alpha beta values than normal tissues. Rapidly proliferating normal tissues also have higher alpha beta values, but tissues and tumors with lower alpha beta values are more susceptible to large doses per fraction. Now, one way to remember this is think of the original application of stereotactic radiosurgery back in the day. When this technique was first introduced in Scandinavia in the late 60s, it was typically used in patients with vestibular schwannoma. And the reason that was the case is these are slowly proliferating tumors, slow-growing tumors with long natural histories, which have lower alpha beta values. They're more susceptible to large doses per fraction. Today in clinical practice, one of the tumor sites where hypofractionation has become all the rage and is in vogue is prostate cancer. Many of you might be practicing at CyberKnife centers, and 5-fraction CyberKnife radiation delivery for prostate cancer is all the vogue, all the rage. And this is possible because of prostate cancer's low alpha beta value. So remember, tissues and tumors with lower alpha beta values are more susceptible to large dose per fraction. How does this look graphically? So there are 3 different color curves on this particular graph. The x-axis represents dose per fraction, going from 0 to 20 gray per fraction. The y-axis represents EQD2, represented from 0 to 140 gray for different alpha beta values. Blue is an alpha beta value of 10 gray. Red is an alpha beta value of 1.5 gray. Think of blue as rapidly proliferating tissue or a rapidly proliferating tumor. Think of red as slowly proliferating normal tissue. And green is intermediate with an alpha beta of 3. Let's now look at radiosurgery as an example. Let's say you were to prescribe a dose of 13.5 gray in a single fraction with radiosurgery. If you were to do this, what does this mean in terms of fractionated EQD type dose for tissues with different alpha beta values? For the curve in blue, that is tumor, alpha beta 10, rapidly proliferating tumor, maybe rapidly proliferating normal tissue, the equivalent dose is about 26.4 gray. Whereas for the red curve, which is alpha beta of 1.5 gray, slowly proliferating tissue, think of normal brain. That's like 57.9 gray. So if you were to treat a brain metastasis, a rapidly proliferating brain metastasis, say for example from non-small cell lung cancer, and deliver 13.5 gray in a single fraction, you would be giving it the equivalent of about 26.4 gray. But the same brain surrounding that lesion is seeing the equivalent of about 57.9 gray. Clearly 13.5 gray is going to be inadequate to control a brain met. And that's why we typically don't use doses as low as 13.5 gray for most brain mets. We use much higher doses. So this is a useful way to think about how the alpha beta value of your target determines whether your single dose is adequate or inadequate and what doses you need, but also what the susceptibility of normal surrounding tissues is based on the alpha beta value of the normal surrounding OAR. Now, beyond alpha beta, your position on the slope matters hugely. So let's look at a tumor control probability curve where on the x-axis you have dose, represented in this case as an EQD2, and on the y-axis you have the incidence of tumor control going from 0 to 100%. At first, you're working hard. You're going up the dose slope without getting much cure. But then after a while, you're rapidly climbing up the escalator of cure, and then the S-shaped curve starts plateauing out at the top, where incremental increase in dose results in lesser and lesser increase in tumor control. You are increasing tumor control, but you're increasing it less and less. In other words, somewhere in the middle of the curve or in the lower third of the curve, a small change in dose will make a very big difference. This is where you can improve tumor control probability dramatically if you're giving relatively low doses. On the other hand, when you're pretty much near the top, when you're at around 90%, 85% tumor control probability, that same small change in dose will not make a big difference or a big improvement in tumor control probability. And for many tumors in clinical practice, this is actually where we are. For many tumors that we treat, we can get pretty decent doses in. Yes, of course, we have several examples where the dose we give is inadequate. But for many common tumors that we treat, the dose that we give is usually sufficient. And therefore, a small change in dose is not going to make a big difference because we're already on a tumor control probability slope where that difference is going to be small. In contrast, normal tissues behave very differently, and we'll come back and take a look at that in a minute. But I want to give you an example about how improving the dose by a small amount, as we did here, in a tumor that can effectively receive a high dose of fractionated radiation will not make an increasing difference in tumor control probability. And that example I picked from this prospective randomized trial. This trial is known as the SPACE trial. There are many issues and problems, and one can tear this trial apart. But let's focus on the trial as an example of the paradigm. SPACE stands for stereotactic precision and conventional radiotherapy evaluation. This was a Scandinavian SBRT randomized trial in lung cancer. So patients with T1, T2, N0, less than 6 centimeter, good performance status lung cancers. So these are relatively favorable early stage node negative non-small cell lung cancer patients were randomized to the conventional arm, and in the conventional arm, they gave 70 gray. So a pretty decent dose. 2 gray times 35, 70 gray in 7 weeks. This is probably sufficient to achieve decent local control for this not so large non-small cell lung cancers with node negative biology. The experimental arm was 66 gray given in 3 fractions of 22 gray each. So very substantial hypofractionation. SBRT scheduled 66 gray. If we look at the overall survival in the SPACE study, either by intent to treat or per protocol, there is absolutely no significant difference in overall survival. So although the dose has been dramatically escalated in the SBRT arm to 66 gray in just 3 fractions, one does not see an improvement in overall survival in this disease. There are 2 potential explanations. One explanation is that patients are dying of metastatic disease. Everybody has metastatic disease. It doesn't matter what you do locally to the tumor, patient's survival is going to be reflected by metastatic progression. That was actually not the case in this study because they had specifically selected N0 patients, so they do not rapidly die of metastatic progression. So then the second explanation has to be the logical one, that in lung cancer, there was no benefit from SBRT. This is a high alpha beta tumor, and SBRT did not produce a significant benefit. And was it because we were here at the top end of the survival curve, where a small escalation in dose or even a large escalation in dose is not going to make that much of a difference, at least not statistically measurable in a modest-sized trial? Now, as I mentioned, late effects and normal tissues can be very different, because usually with late effects, we start off at the shallow end of the curve. We want to keep the late effects as low as possible. And because we want to keep the late effects as low as possible, a small change in dose here will make a very big difference. So even a slight escalation of dose can dramatically increase side effects. And so remember this when it comes to OARs relative to tumors when shifting from conventional fractionation to stereotactic body radiotherapy, or SRS, that it's very, very easy to damage OARs because you're already at the shallow end of the curve and you can quickly go up very rapidly. Here's an example from clinical practice where this is actually reflected. This was a clinical trial that we worked on several years ago when we started introducing SBRT for non-small cell lung cancer using tomotherapy. And we started noticing that some patients were developing rib fractures, which was an unusual complication because conventional radiotherapy does not produce rib fractures. So we started looking at the dose to the chest wall and computed the incidence of rib fractures as a function of the dose delivered. All patients were treated with 12 gray times 5, and we quickly realized that we could develop a model that could predict the risk of rib fractures. And in fact, the shape of this curve mimics the complication probability curve shape very, very accurately. This is a hypothetical curve. This is the observed curve. And as you can see, when you go up in dose just a little bit, after a threshold of about 45 gray, there's a rapid increase in the incidence of rib fractures. So small increase in dose after you cross the threshold quickly gets you to a high incidence of normal tissue complications. Now, not all normal tissue complication curves are that sharp. Some are shallow. These are very old data published by John Flickinger in the Red Journal, where he looked at the incidence of 5th, 7th, and 8th nerve cranial palsies in patients receiving stereotactic radiosurgery, primarily for vestibular schwannoma. And as you can see, these are relatively shallow curves. They're a function of dose and they're a function of length. And we'll come back to that length concept in a bit. But again, the principle is the same. A small increase in dose can have a significant increase in OAR complications. This is the volume effect. The length of nerve irradiated also adds to the complication risk. It's not just the dose. The more volume of nerve that you treat, the greater the complication risk. So it's just not the increase in dose, it's the total amount of tissue that's exposed to the high dose that matters. And in fact, the total amount of tissue can vary based on the scenario that we're looking at. Going back to our lung cancer experience, this was a different trial that we published in 2013, where we aggressively hypofractionated non-small cell lung cancer patients using a regimen that was fixed at 5 weeks duration, but the dose per fraction was escalated for each patient. And when we looked at grade 4 and grade 5 toxicities, specifically looking at bronchopleural fistula or bronchomediastinal fistulae, what we found was that even a small increase in dose to a tiny volume, which is graph B in this particular slide, You can see that we're looking at volumes of 1 cc in yellow, 2 cc in blue, 3 cc in black, and the Dmax dose. A small increase in dose to these small volumes results in a significant increase in complications. So it's not just an increase in dose, it's an increase in volume. When you go from 1 to 2 cc, there's a significant increase in complication risks. So why do we see this phenomenon of volume playing a role in certain situations very dramatically, and in other situations less so? And in part, that has to do with parallel versus serial organization of functional and volumetric subunits. The example of lung, liver, and kidney, we're not talking about bronchus. The example I showed you was the example of a bronchus. If we take the examples of lung, liver, and kidney, these are organs that are typically parallel in nature. So if you assume that functional loss is represented by the blue squares and all by the red squares, and the blue squares represent the continuing functional subunits, you have lots of functional subunits that are doing all the same thing, so you don't see the impact of knocking off the functional subunits. In an example of this nature, even if you just go up in dose, you're not going to see a complication. You need to treat a very large volume and knock out lots of functional subunits before you see that. In contrast, when we look at examples such as a spinal cord, bowel, esophagus, or as I showed you in the previous example, the tracheobronchial tree, which are serial in organization, inactivation of one or just a few functional subunits can lead to a binary response in terms of losing that functional subunit or not, and the rest of the functional subunits in the chain will be rendered ineffective. And the complication risk is therefore influenced here by the hotspots. It's not the volume you treat, but where the hotspot lies. For things like lung, liver, and kidney, the complication risk is influenced by the dose distribution to the total volume, the number of functional subunits that are knocked out. The second R of radiobiology that's critical here is repopulation. And the reason repopulation is important is we're dealing with acceleration. Repopulation significantly modulates acceleration. So I'm going to skip this particular slide and go straight to a clinical example to show you what I mean by this. These are two clinical trials. The first is a clinical trial that most of you have probably never read. It's a very large 563 patient randomized clinical trial in non-small cell lung cancer patients. 563 patients were randomized to conventional 60-grade radiotherapy once a day, or 3 times a day TID radiotherapy to 54 gray. Nobody uses TID radiotherapy for lung cancer in practice today, but this was a big thing back in the day, and this trial was known as the CHART trial, continuous hyperfractionated accelerated radiotherapy. So the radiation is given continuously every day, including the weekends, 3 fractions a day. Patients were hospitalized, and of course it's accelerated, and all of this is done in 2 weeks. So TID radiation 54 gray in 2 weeks versus 60 gray in 6 weeks. And in lung cancer, the 2-year survival actually improved from 20 to 29% with a p-value of 0.008. If you had a drug today that improved lung cancer survival by almost 10 percentage points with a p-value of 0.008, it would be a blockbuster drug. And yet TID radiotherapy never took off in the management of lung cancer. There are different reasons for that. But the principle here is that shortening the time, acceleration of time, compression of time, overcomes repopulation, acceleration of tumor clonogens, and shortening the time matters in rapidly proliferating tumors. And this is a very dramatic and clear example of that. A second study was attempted in the US, where a version of CHART, known as HART, where the C, the continuous, was removed so patients could get a weekend break, was delivered. This was done in 2.5 weeks. And here again, the results are the same. The 2-year survival went up from 20 to 37% when the radiation was given once daily versus 3 times daily. This trial did not reach statistical significance because the N was small, but established the same principle that TID radiotherapy could overcome accelerated repopulation in rapidly proliferating tumors, and therein lies the benefit of compressing time. When we do hypofractionation and give the radiation dose very aggressively over a few short fractions, we're effectively doing the same, we're compressing time. Now, there are other effects of aggressive hypofractionation that need to be kept in mind because these are typically not addressed with the conventional R's of radiobiology. And two of these are the phenomena of vascular collapse and immune stimulation. And just a word on both of these phenomena. Vascular damage is a function of dose per fraction. In this preclinical model, where radiation-induced vascular damage was studied in tumors, the damage from stereotactic body radiotherapy and stereotactic SRS was modeled and studied as a function of different fractionation regimens. You see three fractionation regimens on this graph. The regimen at the bottom, the triangles, is 20 gray times 1. As you can see, within 10 days after completing the first dose of radiation, there's substantial reduction in the vascular volume, very dramatic collapse of the vascular endothelial system. The most gentle schedule here is 2.5 gray times 8 fractions, which is the closed dark circles. And you can see that the vascular collapse is significantly lower in this context. So the cell death that we see with the typical R's of radiobiology is also differentially modulated by different degrees of vascular collapse. One sees greater vascular collapse with aggressive hypofractionated schedules of radiation, and many effects of SRS and SPRT could be attributable to vascular damage. The best example of this is perhaps in the central nervous system, where following stereotactic radiosurgery, we often see the phenomenon of pseudoprogression or the so-called early necrosis, where we see ring-enhancing lesions that are not tumor, but clearly represent vascular collapse and inflammation as a consequence of that. The second phenomenon that is associated with large dose per fraction radiation is an immune stimulatory effect of high dose per fraction of radiotherapy. On the left is the impact of conventionally fractionated radiotherapy. You get cell death, you get endothelial apoptosis, you get microvascular dysfunction, tumor cell damage, and tumor cell death. The red arrow represents the bulk of the damage, tumor cell damage. The blue arrow is the endothelial apoptotic collapse. It is not as large a component as you would see with single doses of radiation in 8 to 10 gray per fraction or higher. So when we go to the left with single doses of radiation, 8 to 10 gray, of course, tumor cell damage is still the major modality of cell death, but microvascular dysfunction now becomes significant, and hence the size of the blue arrow, emphasizing that this is a bigger component of cell death. But increasingly, we are realizing that we may be stimulating the immune system. So tumor cell death results in the release of neoantigens, which stimulates the immune system, and an immune response kicks in, which contributes to tumor cell death as well. So there could be a third component, not just direct tumor cell death from radiation, not just microvascular dysfunction, but also greater immune stimulatory effects of large dose per fraction radiation. And these are not modeled in the conventional R's of radiobiology. We know that the antigen release that is observed is in fact radiation dose dependent. If we change the radiation dose, here are 3 examples going from control A to the middle panel B to the extreme panel on the right C. The doses go up from 5 times 3 to 1 times 15. So 15 gray times 1 is the panel represented in C. 3 gray times 5, the same dose of 15 gray, but now given in 5 fractions, is represented in B. As you can see, there is a clear and significant increase in antigen release as a function of the hypofractionated dose of radiation. The larger the dose per fraction, the greater the antigen release. But it's not all one way. You would think that if 15 gray times 1 is better than 3 gray times 5, then why not just give 25 gray times 1? Well, it turns out that there is actually a sweet spot. So in this particular experiment that Devan and colleagues published in Clinical Cancer Research in 2009, they implanted a primary tumor in a rodent model and a secondary tumor. The primary tumor was irradiated, the secondary tumor was observed. These animals were given different fractions of radiation, and the radiation fractions were combined with an anti-CTLA-4 antibody. The secondary tumor was always observed. The fractionation regimens are illustrated here: 6 gray times 5, 8 gray times 3, 20 gray times 1. The 3 and the 5 fraction regimens yielded responses in the treated tumor, but also in the contralateral untreated flank. The non-irradiated tumor also responded, which clearly implies an abscopal effect, an immune stimulation effect that is harnessed and seen with the 3 fraction regimen and the 5 fraction regimen. But the single fraction regimen, which was a 20 gray regimen, did not show a response in the contralateral lesion. So this is a surprising finding, that although we see that antigen release goes up as a function of dose, there is a sweet spot when it comes to stimulating the immune system to create an effect on an untreated lesion. You don't see that endlessly as a function of dose. You still need high doses per fraction to generate this response, but there seems to be a sweet spot in the 6 to 8 gray per fraction range. And the presumptive mechanism for this is the differential stimulation of different pathways in response to radiation and DNA damage. The presumption is that the sweet spot, such as 8 gray times 3, is far more capable of activating the C-gas and the STING pathway compared to large fraction radiation, such as 20 gray times 1. And it's the stimulation of the STING pathway that results in the release of interferon alpha and beta, which brings dendritic cells, which allows recruitment of CD8 positive T cells, hence allows an immune response to be mounted. And so the synergy with CTLA-4 agents and presumably with other immune checkpoint inhibitors is probably best seen in the sweet spot of 6 to 8 gray per fraction. This is again an unknown effect previously of hypofractionated stereotactic radiotherapy, which may well be playing a significant role in the clinic. So let's bring this all together into the clinic. Hypofractionation in the clinic is inherently dangerous, so don't do it because of its greater impact on late reacting normal tissue. It requires extremely precise dose delivery. So if you don't have precise dose delivery and image guidance, this is dangerous business. More precise dose delivery leads to dose compression, time compression, and higher partial volume OAR dose per fraction, resulting in novel side effects. I showed you the example of the bronchial fistulae by just treating 0.1 cc of the bronchus to a high dose of radiation. So these are novel complications that we're not used to seeing in conventional practice. These are things that happen that are inherently dangerous. However, it is also extremely advantageous for tumor control. So please do it, but do it from the perspective of safety, which requires very precise dose delivery and good image guidance, from the perspective of acceleration in rapidly proliferating tumors, possibly from immune enhancement, maybe from vascular collapse, but that can go both ways. It's a double-edged sword. Vascular collapse in normal tissue is just as bad as vascular collapse in tumor. And this can potentially give you higher tumor control possibilities, but can also lead to higher complication rates. And so the physical dose distribution advantages and understanding your OARs becomes crucial to practicing SRS and SPRT in a safe manner. I was going to show you additional future examples of hypofractionation by going into the oligometastasis paradigm. I think I'll skip that in the interest of time. So let's move on to the remaining two topics. The remaining two topics will focus on alternative delivery methods, in this case protons and neutrons. I'll start by telling you that protons are the same as photons. There's absolutely no difference. It's just photons times 1.1, or maybe not. Maybe there's a little more to this story. And of course, there's a little more to the story. Hence, it's a topic of conversation for us today. And then I'll end with a little bit on neutrons. Let's start by defining RBE in simple terms. RBE is the dose from a standard, in this case gamma radiation, versus the dose from an alternative modality, in this case protons, for the same effect. So if you need a smaller dose with protons to have the same effect as you would with gamma radiation, then your RBE will be larger than 1. And conversely, if your experimental radiotherapeutic modality requires a larger dose for the same effect, your RBE will be less than 1. So this is really how RBE is computed. But it's kind of important to realize that the RBE is going to vary based on where you compute it on the cell survival curve based on the effect. So RBE will vary. If you look at this example, we measured it at 0.1 cell survival. If we measure it at 0.01, the RBE number is going to be different. If we measure it at 0.001, it's going to be different. So RBE is going to vary based on the definition of the effect. So it is tied to the effect of interest. Now for protons, we say RBE is 1.1 across the board for everything. For tumors, normal tissues, whatever dose you use, it doesn't matter. That inherently makes no sense. When we look at the data, these are the in vivo proton RBE data from the literature. This is a famous publication by Paganetti. You can see that the numbers are actually all over the place. And this little red dotted line, that's my creation that I put there in the middle, is the 1.07 plus minus 0.12. This is how we sort of came up with 1.1. You know, if you remove that line, I don't know how you're going to come up with a 1.1 number here. You know, this is really all over the map. We presume that in the clinic, this is how the proton RBE behaves. We have a physical dose at the bottom in red, which is a Bragg peak, a spread out Bragg peak that you can see here, low dose at the entrance, and then you see a plateau of multiple stacked up Bragg peaks, and then a quick rapid fall off. And the bioeffective dose is just multiplied by 1.1, and you put it on top there, so it's 10% higher. This is what we assume actually happens with an RBE of 1.1. In reality, that's furthest from the truth. Because we know that the RBE changes with a lot of things. RBE changes with LET. It changes with dose per fraction. It changes based on the alpha beta property of the tissue that's being irradiated. So for example, in the first example on this slide, the solid line represents an alpha beta of 2 gray. The dashed line represents an alpha beta of 10 gray. And you can see that the RBE is dramatically higher for an alpha beta of 2 gray compared to an alpha beta of 10 gray. The different numbers here are increasing LETs. As LET goes up, RBE goes up. So RBE is always higher for tissues with lower alpha beta ratios. Remember that. The other important thing is the middle panel. The RBE is higher with lower fractional doses. If you look at the right-hand side of the graph at around 8 to 10 gray, the RBE values are lower for both the alpha beta 2 tissues and the alpha beta 10 tissues. But if you go to the left of the graph, closer to 2 gray and smaller, which is conventional fractionation, as the fractional dose decreases, the RBE goes up. Why is this important? When we look at a proton depth dose curve, we have a Bragg peak in the center. The Bragg peak in the center is in the GTV. It's the highest dose region. This region actually has the lowest RBE. The highest RBE is actually in the lowest dose regions, i.e. the OARs. And I call this triple trouble. The reason the RBE is highest at the distal edge is because the dose per fraction is lowest at the distal edge. Therefore, the RBE is higher. The energy of protons has declined, and the RBE goes up as the energy goes down. And of course, the alpha beta is in normal tissue now we're looking at it, so it's going to be most likely lower, and therefore the RBE is higher. So 3 factors contribute to an RBE going up at the tail end of this dose deposition: a reduction in dose per fraction, a reduction in energy, and a reduction in the alpha beta value of the tissues because you have transitioned from tumor to normal tissue. And as a consequence, the RBE here is going to be probably much larger than 1.1. And as a consequence, the real clinical RBE distribution, bioeffective dose distribution, might well be like the graph that you see on the right, where it may only be 10% higher at the plateau, but right past the Bragg peak at the tail end at the distal edge, it may be 20% or higher. So the RBE may be 10% higher than we have assumed it to be, and it could be even higher than that before it starts dropping off. Why does this matter? It matters because, as you can see from images A, B, and C on the left-hand panel of a patient treated with a central nervous system tumor, we see these post-treatment imaging changes. These are asymptomatic late-phase radiographic changes that are seen in patients. And these are curious findings. We don't understand this. And when we map these with physical dose, they're right at the edge of the high dose. They seem to be somewhat related to high LET, but it's not purely related to high LET. And so there are different models that are now being developed to try and understand why we get this distal edge effect. And this is something one has to be aware of in the clinic. In fact, an increasing concept that's being proposed is that different tissues have different RBEs, different endpoints have different RBEs, and therefore we should be using proton RBEs that vary based on the tissue and the target. So the dose deposition should be represented not just as a uniform physical dose, but modulated by RBEs of tissues of interest. So what are the conclusions about proton RBE? The 1.1 estimate is okay in the clinic, but please recognize that it is a very simplistic average with considerable variations as a function of tissue alpha beta ratios, endpoints of interest, dose per fraction, location within the spread out Bragg peak, as well as the parameters of the proton beam, the dose fluence, the energy, the LET. And perhaps future planning could be LET based and help solve some of these issues. There are other radiobiological considerations with proton therapy. I'm not going to go through all of these in the interest of time. The slides are available for you. This is a very interesting reading because these suggest that there are other benefits of proton therapy beyond just simple dose distribution and an RBE of 1.1 that might be worth thinking about in terms of the effect of proton therapy on tumor outcome. So I'm going to skip these slides on lymphopenia, which is a very interesting concept, and go to the last component of my talk, which is neutrons. So there are very few places where neutron therapy is delivered today. You still get a couple of board questions once in a while. So let's do a quick recap of the history of fast neutrons. So what are fast neutrons? Somewhere in the range of 1 to 20 MeV. These are somewhat arbitrary definitions. There are all kinds of commissions that were set up to name these neutrons based on their energy. But fast neutrons for clinical purposes, generally 1 to 20 MeV. The initial work was done at Lawrence Livermore Berkeley Laboratory as well as Hammersmith in the UK. And the initial conclusion after years, decades of experimentation was not worthwhile for most tumors. Done and dusted, end of story. So why were they pursued at all in the first place? Potential advantages of neutrons include high LET and high RBE. Some have speculated up to 10. Most people say 1 to 3, 1 to 4, but some have speculated all the way up to 10. So think of this. We said protons is 1.1, right? Neutrons is much, much, much higher. So higher RBE may be better tumor kill. We know that in many tumors, hypoxic cells are rate limiting for cure. And the OER, the oxygen enhancement ratio for neutrons, is actually very high. It's around 1.6. And so this might actually be especially effective in hypoxic tumors. Think glioblastoma, for example. The higher RBE might have great benefit in slowly proliferating tumors. And back in the day when these experiments were being done, slowly proliferating tumors were not commonly being treated in the world of radiotherapy. And so this was thought not to be an issue. But think about one of the most common tumors we treat today, prostate cancer. It's a slowly proliferating tumor. Think about that, okay? But there were technical challenges with this therapy. Neutrons were generated in cyclotrons by smashing protons or deuterons in a beryllium target, read nuclear reactors. So you actually had to take patients to nuclear reactors, something that was never going to work in the first place. The beams had poor penetration characteristics because they were typically at the lower energy range. Their characteristics were not optimized. We didn't understand how to fractionate neutrons. And remember, neutrons have no Bragg peak or depth dose advantage like protons do. In fact, the depth dose distribution curves of neutrons look very much like those of photons. They don't look much different. Of course, this is enormously expensive to go to a nuclear reactor to treat patients. And we had no clue how to understand the RBE effect of neutrons, and this led to unexpectedly high toxicities. But in spite of all of this negativity, some value was demonstrated, especially for salivary gland tumors, melanoma, sarcoma, Aha, prostate cancer, slowly proliferating tumors, as well as bladder cancer. Now, the reason I'm showing you some of the slides on neutron therapy is although neutron therapy has not experienced a resurgence, BNCT, boron neutron capture therapy, is beginning to experience a resurgence. So what is BNCT? Is it boron therapy or is it neutron therapy? Well, it's actually neither. The therapy is not neutrons. Neutrons is not the therapy. Neither is boron. Boron is inert. Boron is not the therapy. The therapy is actually short-range, high-LET alpha and lithium particles with about a 12 micron path length with a very high LET of about 200 to 300 keV per millimeter, hence a very high RBE. And this could, in theory, achieve 3-to-1 or 4-to-1 tumor to normal tissue dose and killing. So this could be a very effective way to kill tumors. There are several challenges. The first challenge is where do you get the neutrons from? The age-old problems. Take the patient to the reactor. So reactor-based neutron sources, challenging, very difficult to pull off, practically impossible. Drug selection is another problem. The drug must be tumor specific. If the drug incorporates in normal tissue, boron will be in normal tissue. You will get the high LET effect in normal tissue. The complication rates will be very high. So tumor specific drugs are necessary. What do we have as a revolution in medical oncology today? Tumor specific drugs. Think of the vast majority of tumors. HER2 positive breast cancer. You got a HER2 targeted drug. Think of an EGFR mutated non-small cell lung cancer. You've got an EGFR targeted drug. Think of a BRAF mutated melanoma. You got a BRAF targeted drug. Think of almost any disease. We are now beginning to find very specific targeted drugs to those drugs. And the entire world of medical oncology is swamped with antibody drug conjugates based on this principle. Deliver the drug specifically to the tumor using an antibody drug conjugate. Why not use that to create an antibody boron conjugate? And now we can deliver boron specifically to the tumor and then optimize the use of neutron therapy. So it is this biology, this revolution in drug development that is occurring across the globe that is leading to a resurgence in BNCT. But a second thing that's beginning to make an impact is the fact that the neutrons that are used for boron neutron capture therapy are not the fast neutrons that we talked about on the previous slide, but typically they are thermal or epithermal neutrons that are used for this. And the reason for that is thermal and epithermal neutrons have the highest cross-sectional area of interaction with boron. They still have poor beam penetration characteristics, so it kind of limits its use in very deep-seated tumors. And so there is that limitation that still exists based on the quality of the neutron beam itself. So what's the current status for BNCT? So we now have accelerator-based, hospital-localized systems that can produce thermal and epithermal neutrons. You don't need to go to a nuclear reactor. So these are now available. They're manufactured. There are several systems operational in Japan. The first system has gone live in China and has been treating for several months. There are 2 systems in Finland now, and several other countries have systems underway and in development. And the early results look rather promising. For example, in Japan, based on a trial in recurrent head and neck cancer, where the complete response rate to BNCT was around 50% with just 1 to 2 treatments. Boron neutron capture therapy was approved for use outside of clinical trials. And now in Japan, one can actually receive BNCT for various recurrent neoplasms. The initial data are very promising in recurrent glioblastoma, in melanoma, in angiosarcoma, in recurrent head and neck cancer, in chondrosarcoma, and in a number of other diseases. But most excitingly, there is a robust novel drug development program that is underway where very specific tumor-specific molecules are being designed. So this could be a potential wave of the future where neutrons come back, but they come back in the form of BNCT, which is essentially high LET radiotherapy that's tumor-specific. So that leaves me 5 minutes. I wanted to end with 2 sample questions and then open it up for questions from anybody who's listening, and we can take questions from you guys as well. So let's take 2 sample questions. I created my own questions just because this was a way for me to think about some of the lessons. So suppose I asked you this question. This question could be 4 or 5 different questions that could be posed to you. Gamma rays and X-rays. What is the LET? What is the Bragg peak? And what is the RBE? So it's the same question for each of these 4 beams. Gamma rays, X-rays, protons, neutrons, and heavy charged particles. What's the LET? What's the Bragg peak? And what's the RBE? So if you have a piece of paper, write down your answers, because in about 10 seconds, I'll give you the answers. But, be fair to yourselves, write your answers down. Don't wait for the answers to come. It's actually quite simple. And here are the answers in blue. Gamma rays and X-rays, low LET, obviously no Bragg peak, and an RBE is 1, because that's what we use for standard comparison. Now remember, the standard comparison is gamma, so X-rays have slightly different RBE than gamma, but good enough for jazz. We'll take 1 for X-rays. Protons, low LET for the most part, with a Bragg peak, so major dose deposition advantages. And in RBE, we say of around 1.1, but you saw all the caveats around 1.1. Neutrons, very different, high LET, right? 3 to 4 times, maybe 10 times, some say. No Bragg peak, that's the problem. No dose distribution advantages. And very high RBE. Okay, this is fast neutrons, remember. Okay. Heavy charged particles, high LET. They actually do have a Bragg peak. That no Bragg peak is a typo. I copied and pasted that. It shouldn't be there. There should be Bragg peak. And high RBE. So heavy charged particles have an advantage in all 3 domains. High LET, they do have a Bragg peak, and high RBE. And hence the interest in heavy charged particles. But this is one way to think of these different modalities that then gets you to each of these concepts and then try and understand the concepts in detail. Let's take one more question. This is a question on fractionation. So try and answer this in your mind, and then I'll show you the answer at the end. When switching treatment from conventional to extreme hypofractionation, which is what we do with SRS or SPRT, which of the following is not a concern? A, the volume irradiated. B, the proximity of high alpha beta OARs. C, serial versus parallel organization of proximate OARs. And D, potential for immune enhancement in the oligometastasis setting. Now, in all fairness, I skipped those slides, so I'll give you that one, as that does matter. So here's the answer. B is not correct. Remember that the tissues at greatest risk for harm when you go from conventional to extreme hypofractionation have low alpha beta ratios. So normal brain, for example, which has low alpha beta, would be more susceptible. But high alpha beta ratios would be less susceptible to damage from extreme hypofractionation compared to normal fractionation. Obviously, volume irradiated is very important. The bigger the volume, the greater the toxicity. You saw that with the cranial nerve example I gave you. You saw that with the rib example I gave you. You saw that with the bronchus example that I showed you. Obviously, serial versus parallel organization is very critical. Again, the bronchus was a very good example of serial organization. Small 0.1 cc difference in volume makes a big difference because it is serial. And the potential for immune enhancement, as I mentioned, I didn't show you the slides, but they are there in the slide data, so you can look that up. So with that, I still have a minute. So if there's a couple of questions, I can take those before I spring you free. And if there are no questions, that's okay. I know it's
Just
late
have
in
one
the hour,
question.
coffee time. Go ahead.
Thank you for the presentation, but in this question, D is also not a concern, no?
Okay, so you are correct. You can't say that's not a concern at all. Okay, so I could have phrased the question a little bit better. I would, I use the word not a significant concern. Of course, proximity of any OAR is a concern. It's always a concern. What I'm trying to emphasize here is that the lower OAR structures are going to be damaged much more easily and rapidly with an escalation in dose compared to lower alpha beta tissues in the vicinity of it. So rather than not a significant concern, I should have phrased it a little differently. The idea is to try and get you to focus on the differences between higher and lower alpha beta ratios in terms of sensitivity to change in dose per fraction.
So low alpha beta ratio gets more affected when there is extreme hypofractionation than high alpha beta ratio?
Yes, let me show you that slide again, just to get back to that. That was one of the early slides that we looked at here, right here. Okay, so remember this particular slide, we're on the x-axis, we're the dose per fraction, we're doing stereotactic radiosurgery type of radiation. We use 13.5 gray as an example, and we use different alpha beta ratios for different tissues of interest and computed the EQD2. So the tissue in blue, which has alpha beta of 10, which is rapidly proliferating tumor, has the lowest dose. The equivalent of 13.5 is 26.4. But tissue in red, which is an alpha beta of 1.5 gray, like normal brain, the dose of 13.5 gray is roughly equal to 57.9 gray. So the impact on high alpha beta value tissues is lower compared to that on low alpha beta value tissues. And so your normal tissues, normal OARs, if they have an alpha beta of 1.5, you'd be much more concerned than if they had an alpha beta of 10. I hope that clarifies.
Thank you.
Okay. There's a question here that showed up and it disappeared. Nitesh Chopra had a question. Do you want to voice it? Because it showed up and it disappeared and I can't find it now.
Sure. Thank you for the talk, Dr. Mehta. My question is regarding large volumes I often see getting hypofractionated stereo treatments in the clinic, and my initial reaction to that is of concern, and I'm just trying to get more clarity on why this is becoming more and more common that is safe, because I know one of the considerations is the volume, and smaller volume mets are more readily treated with stereo hypofractionated treatments, right?
So there are two parts to your question, Nitesh. The first part is that as we treat larger and larger volumes, there is concern for normal tissue toxicity. Because remember that whenever we treat any structure with whatever dose, and let's roughly say our dose deposition is spherical, you have to deal with the dose fall off from that structure. And the larger the volume of that structure, the larger the volume of that dose fall off. If you have a larger volume of dose fall off, there's a greater probability that you have some critical structure in that dose fall off. And if that critical structure is serial rather than parallel and it's in a high dose near the hotspot, you're increasing the chances of getting in trouble. So there is, in fact, a volume limitation beyond which aggressive hypofractionation may not be safe because you're inadvertently going to hit something critical and cause complications. But there is a second problem. Because as physicians, we take the Socratic oath of do no harm, primum non nocere, okay? We want to do first no harm. What do we automatically do when we treat larger volumes? We treat smaller doses. We deliver smaller doses. We decrease the dose. And as we decrease the dose, and this is very common in radiosurgery, if you look at the original Ed Shaw paper from the very first RTOG radiosurgery trial, smaller brain metastases are treated to a higher dose. Larger brain metastases are treated to a smaller dose. Dr. Miller gave the talk earlier. He gave you the examples of how many clonogens, how many tumor cells there are, even in just 1 gram of tumor tissue. And yet we do the opposite in practice. We decrease the dose as the number of cells go up. And the reason we're doing that is for the sake of safety, not for the sake of tumor control. And of course, the bigger and bigger tumors that we treat, we get to a point where the dose becomes ineffective. So this particular graph is a perfect example of that. So suppose you were treating this particular metastasis, call it a 6 centimeter metastasis. You decide 13.5 gray in a single fraction is safe for a 6 centimeter metastasis. So you give it 13.5 gray. You've essentially given that tumor 26.4 gray. 26.4 gray is never going to control a 6 cm lesion. So that's the second challenge in practice, that when we treat larger and larger volumes with aggressive hypofractionation, we may be underdosing the tumor because we are trying to protect the patient. So that we are losing the balance. I think that's why in my concluding slide about hypofractionation, I put in the significant and catchy phrase that it's inherently dangerous. Therefore, don't do it. But if you are going to do it, choose your patients right, because it is advantageous for tumor control. So selection of patients is crucial. This is not for everybody and all patients. So with that, I'm way past my time, and I should yield back the time so you guys can stay on time. Thank you very much.
Thank you, Dr. Mehta.
Pleasure.
All right, let me get my slides ready. Well, this lecture is about a subject near and dear to my heart, because back in my research days, I used to research things having to do with tumor hypoxia. So this one is going to be right up my alley, unlike my one this morning about DNA damage response. So, ostensibly, the name of this lecture is the tumor microenvironment, but as we're going to learn, hypoxia has a whole lot to do with how the tumor microenvironment works. So let's start out by defining what actually is the tumor microenvironment and what's in it. So basically, it's all the cells, the proteins, extracellular